Thank you.
All right.
Welcome, everyone. Are you a nice looking group of people today?
They are.
Yeah.
What's up? They always are.
Always. Please introduce yourselves in the chat. Where are you from? What organization? And if there's anything super unique happening for the holidays this holiday season, if you have something that you are just really excited about, even, I mean, it can be turkey, if you know, whatever. So if you've got something that you're very excited about, please feel free to put it in the chat. Otherwise, please just let us know where you're from.
Lentil loaf. I'm putting lentil loaf in the chat.
Lentil loaf, that's right, vegan Thanksgiving. No tofurkey this year?
Either that or tofurkey. It all depends on whether I'm going to be industrious and fix it myself or go to the store and say, what's my one big enough?
Sharon, we have Judy, who's from Northeast Iowa. Now that you're in Iowa.
Judy,
Shannon is temporarily in Des Moines.
I'm wintering in Iowa this year.
Welcome, Yolanda. Hi, John. Miranda, welcome.
We have one of our main fearless leader, Adam Vieira, on board, our director. Hi, Adam.
Hi, Adam.
Hi, everyone. Good to see you all.
I'm going to the Wisconsin Dells. That's what Aubrey says. That's cool.
Aubrey, are you going to be going to the Circus Museum while you're there, or like Kalahari Gardens?
Yolanda, that's funny. Fresh fried turkey. Yeah, I hope it's not explosive too. Have your fire extinguishers and everything ready.
Don't watch any of those YouTube videos.
All right. Luke, I love vegetarian spring rolls. Oh, that's
me too.
Good stuff. Mount Olympus. Okay, that's where Aubrey is going to be. Mount Olympus. That's wonderful. Thanksgiving dinner for, that's nice at the community center. Oh, John, that'll be wonderful. Welcome, everyone. Hi, Nia. Hi, Ashley. Mitchell, welcome. Sorry, my computer shakes when the cat jumps. Hopefully she won't knock my computer down this time. All right. Going to visit my spouse and maybe in-laws in Chicago.
That's often. We made the decision this year to not go to Chicago to visit family, mainly because my daughter now has 3 children under the age of 5, and traveling for 2 days is just too much. So we're just going to her house.
So that's a haul there. It's a lot of packing to do. You have to do. Welcome, Edlin. I hope I pronounced that correctly. Edlin, San Antonio. Hi, Deborah. How are you?
Deb. Hi, Debbie.
It's great to see you here. Right.
Debbie, I usually run into you in other TA venues. Good to see you.
And Judy, I'm from Lithonia, Georgia, Metro Atlanta area. Sharon and Cindy, Adam, you want to answer where you're from?
Judy.
And hello, TL. Greetings. Thursday. I love that.
I do too. I'm going to use that. Thank you so much.
Hi, Bree. Welcome. Welcome. Adam is based in New York City, Maryland. Hello. Hi, Stevie. Nice small.
I'm so glad people are showing up. As most of you probably saw, I had this meeting scheduled for 12 a.m. Had a little bit of a freak out.
A wise group of people who
figured it out.
No, yep. Would be like, there's no way Cindy really meant to schedule this in the middle of the night.
Absolutely not. Cindy always saves the day for us. Sabrina Woodstock. She does. A fellow Georgian. I like Woodstock. North, a little northbound from me.
I love these because
Great.
everyone's from just all over the country. It's awesome.
Yeah, this is wonderful. Well, welcome everyone. Welcome Richard, Martha, Sheila, my old stomping grounds in Washington, D.C. Welcome, Oregon. I love Oregon. All right, why don't we get started? Today, we have a special treat. We have Sharon as our presenter, Sharon Hesseltine, and our title is Exploring Warm Handoffs. It's warm, but it's not a handout. A handoff, excuse me. Handoff. The way to get started, right? Well, it's warm, but it's not a handoff. So why don't we get the slides up when we can?
That should be looking the way it's supposed to.
It does. Thank you very, very much. Next slide, please. So we start by introducing our program. Here's our disclaimer. We're funded by SAMHSA. Anyone who would like to read that full disclaimer, you will get these slides in an email after our presentation today, sometime within the week of the presentation. All right, next slide, please. So we are the Peer Recovery Center of Excellence. And what really excites us about our program is that this project is led by those with lived experiences. So we really want and make sure that the peer voice is really at the core of our work. We acknowledge the importance of peers throughout everything that we do. And our key focus areas are integration of peer support services, capacity building, workforce development, and importantly, also bridging the gap between evidence-based practice and practice-based evidence. So this particular project is funded under the Minority AIDS Initiative. We received SAMHSA funding to provide training and technical assistance to support Minority AIDS Initiative grantees. And we wanted to really support them with integrating peer recovery support services into their existing projects and programs, specifically around HIV prevention and treatment approaches. And so part of our goals are to solicit input from grantees and key stakeholders, provide proactive training and technical assistance. And also importantly is to respond to requests for customized TA from individual MAI grantees. So I want to take this time to do a plug, and that's to let you know that if your organization needs specific, really tailored technical assistance, we go through this amazing presentation today, and you find like, oh, you know, we could really use some more specific support around doing referrals and doing them well, then please feel free to apply for customized TA. It is absolutely free, and we absolutely want to make sure that every organization that's interested has access to our information and our experts. So here's where you can find more information. Again, you will receive these slides so you can access the links very easily. We have a TA request form if you do decide this is what you want to do, if you want tailored technical assistance. There's a frequently asked questions, resource library, which is really great. We've got some good information there. You can always email us and reach out if you have any questions. And we've got some direct updates, and you can always click on the bottom link for those updates to sign up to get the updates automatically. And I'm going to turn it over now to Cindy for brief housekeeping. Thank you.
Thanks, Tanisha. And hello, everybody. As always, we want this to be very interactive today. We are recording, and the recording will be made available in the coming weeks. It'll be posted on our website, and you'll all get that in a follow-up email where it is. So we do want to hear from you. So during today's presentation, while Sharon is speaking, please, you can submit questions via chat, but also raise your hand. We'd love to ask you to unmute and ask your question aloud. Also, if you have a webcam, we love seeing your faces. It's not mandatory, but we do like it. Let's see. Yeah, we will be muted, but I will ask you to unmute if you have a question, as I said, and raise your hand. About a week from today, you will get a follow-up email from me that will have the slides with all the live links. We are going to offer, it's not CEUs, it's a certificate of participation. You'll all get one for this presentation. You can take it to your state or other certifying body, and they often accept our trainings and webinars for CEUs because we're federally funded. And we also will put a quick evaluation link in the follow-up email. We want to hear from you. We want to find out what we could be doing better or other topics that you might have for us to present on. And I think that's basically it. I don't think I skipped anything, but please use the chat freely. Thanks all.
Thanks, Cindy. So, Tanisha, do you want me to just go ahead and like jump in, or?
Yes, please.
Were we gonna, maybe you have this already. I just know that we changed the title of this. So I don't know if the person that questioned the title is on, but I thought it was a good point to bring up. So I don't know if that might already be in your presentation, Sharon.
It is in several different ways, but yeah, because we did, I think originally we had the term client there, and we, as I was putting this together, I changed it to participant, and I really appreciate, we received some feedback, about the term client, and it was interesting because it really, I thought about that quite a bit. And in relationship to the different kinds of things that I learned and pulled together as a part of this discussion that's really focused around warm handoffs or referrals. There's a number of pieces that really come into this, but particularly in the beginning, as we look at some definitions, I think it gives us a great opportunity to think about language, the language that we use, and how where language does or does not influence our attitudes and our behavior and our perspective. So I think it's one of the things for me that it really did, and I think overall is so important about it, is around intentionality, and being intentional about our language, but also being intentional in that our actions and our culture and our practices are consistent with the language, because that was one of the things that really just kind of hit me, is that language, we have to do more than change language, we have to go beyond that. So when we were first discussing this particular topic about warm handoffs, I made what I thought was a kind of flippant comment, which I do sometimes, which was, well, they may be warm, but they're not necessarily a handoff. And so it's part of how I think I ended up doing this today, as well as informing the title. But I tell you what, I learned a number of things in the process. So I'm hoping that you all will walk away learning some new things as well. So we're going to take a look at just the term warm handoff and consider that we may have different ideas about what that actually means and what that looks like. We'll talk about the role of peer support in kind of system or service navigation, or linkage and referral, and so on, what that looks like. We want to take a little bit of an opportunity really to share with each other and to think collectively about what are the best practices around referrals. What does that mean, and what does that look like in our organizations? And how do we assure that that is a responsive process for the folks that we provide support services to, and that we're also referring to organizations where the folks that we serve are going to have a good experience. So I'm looking forward to that conversation. And then we're also going to talk a little bit, we'll end with really taking a look at collaboration and community collaboration. What kind of brings me, I think, to have an interest in this and experience in this arena is really having worked in with programs that serve actually families with really young children for quite a long period of time. And this is definitely a population of folks that really benefited from a pretty wide variety of support services. So being able to connect folks that our programs and supports, that we served and that we supported, to services that were really going to meet their needs well, was an important part of work that I was involved in for quite a long period of time. So I didn't say anything about myself, and I'm not going to say much about myself. Part of what brings me to this is that I chaired the steering committee for the Peer Recovery Center of Excellence, which is a great honor. I am a woman with lived experience, and for me, that means that I haven't misused substances for about 18 years and a little bit of change. I do a lot of work with peers in my home state, which is Kentucky, and then also do quite a bit of work and have the opportunity to develop different kinds of training through the Opioid Response Network as well. And I do a lot of the focus of my work has been around peer support and recovery support services for pregnant and parenting families that experience substance use disorder, and as well as in recovery. So all of that together kind of brings me to this, because that is definitely a specific population that always has really pretty significant kinds of needs for a wide variety of services. So just to kick us off, just exploring warm handoffs. As I really started digging deeper into the term and what comes up, one of the things that really hit me is that it's a term that gets frequently used, but I suspect that maybe, we may not all have the same idea of exactly what that means. So just to get us started, I know a lot of folks have put in the chat as far as their name and where they're from and their organization. If you all wouldn't mind just to take a minute and rather than the name of your organization, kind of the type of organization, and then how do you, within your organization and your role, how do you define warm handoffs? My guess is that we may see some differences here, so we'll kind of see how that ends up looking. But if you wouldn't mind just to humor me for a minute and put that in the chat, and we'll kind of see how that ends up looking. So,
Be shy.
hey, the chat is broken. Oh,
No, it takes a minute to write that in. Does anybody want to unmute?
yeah, please feel free to unmute.
That's so much easier.
Yeah.
Yeah.
Go for it.
So I work in a hospital, and one of my responsibilities is to process intakes that are either coming via fax or phone, email. And so I then have to take it up to the ED, get the patient medically cleared by the ED doc. Once he does that, then I come back down and then I consult with the on-call psychiatrist to see if he's willing to accept the patient. This is all, of course, after I've consulted with the house supervisor to make sure we have bed availability. And once all of that is done, I then type all of that up. And traditionally, it's only supposed to go to the charge nurse. But because I want all of the parties that I have consulted with to be abreast of what is going on, I voluntarily make sure that the house supervisor, the charge nurse, the on-call psychiatrist, and the other ED intake coordinators have a copy of the referral packet. And it's very detailed. So literally all they have to do is just like pick up and, take over. So I learned about warm handoffs back in 1998 when I was working in customer service. And so for me, even though it's not required, I do that so people don't have to guess what's going on or go get it from another person. So it's not required, but I do it anyhow.
So let me ask you a question. You work in healthcare, and it sounds like part of, and you'll have to correct me, TL, if I am misunderstanding, but as I listen to you, one of the things I really hear is your commitment to really wanting to be sure that the different members of the healthcare team that the person that you receive the intake in is going to encounter, that they have the best opportunity to understand that person and what their needs are.
Right. So like I said, it's not required, but if I was going to be working with that patient that's coming in, I would want to know everything that's going on with that patient. It's not just, for me, it's not helpful just for the charge nurse to know, even though they do have to come through the ED and get processed through the ED, they're still then going to be taken up to the floor and, admitted into a room. And so I give it to them. I come in the office and I see it still all over, but I'm like, I gave it to you so no one could say, well, I didn't know. So, and I also am very proactive, and I don't want anything to ever fall back on me that somebody didn't get it, because now 5 people have it.
Yeah. Yeah. Well, and it sounds too like you have a pretty strong commitment to patient care and quality.
Right.
As well, which is really great to hear. So thank you for that. And Sheila, I see you've got your hand up. Cindy will unmute you.
Yes, I work in a community outreach program, faith-based. And what warm handoff is for me is making sure that whatever the program is that the participant desires to participate in is to make a contact there to make sure that they have space, availability for them, and that there is someone that will be there when they get there to receive them. That is very important. And then the follow-up to make sure if we didn't take him there and they went on their own, they got there, that they're able to receive the services that they desire.
Okay. So as I'm listening to you, Sheila, part of what I'm hearing too is that you're really making some really intentional efforts to give the greatest opportunity that's going to be a successful referral, not in the terms of you giving it to the person, but that they actually got the services that they need and that they're going to benefit from, and that referral source is ready for them.
Yes. And these are the services that they desire to have.
Right. Awesome. Thank you so much. So, and I'm seeing some things in the chat as well. So some of this, if y'all take a look in the chat, there's a lot of really great stuff in here now, right? At this point, right? One person, Mitchell, is saying warm handoff is when you stay on with the client, as outside services are connected with the peer, and you stay and do this in the capacity acceptable to the peer, right? Sometimes staying on for the entire crisis call, right, to support somebody in that. Nia is saying warm handoffs usually consist of introductions, either in person or virtual, with the referring party, the peer, and TPOR. I know there's more to TPOR. Sometimes I guess at acronyms, but I frequently guess wrong. But one of the things that stands out to me, Nia, in here is that it's trying to introductions between where folks are being referred or connected to and the person being served, whether that's in person or virtually, right? Connecting folks to long-term services, I'm seeing from Donna. And so as I'm kind of looking through this, I see a couple different things. The purpose of recovery. Oh, that is awesome. I want to start using that. That is just overall. The part of what I'm seeing is I look at these and hoping that you all see some of the same things. This is that how a warm handoff looks in our organizations isn't identical, right? Across all of our organizations, and which is what I kind of figured may happen. Judy is, and you are CCBHC. So Community Coordinated Behavioral Health Center. Is that accurate, Judy? I've done a little work with CCBHCs, but I don't always have the acronym accurate. So, oh, cool. Thank you. Right. So what we're looking at, and for some folks, it's really about that in-person or kind of virtual, quote, in-person introduction. For other folks, it's really about a referral that is to organizations that that maybe you have followed up with to be sure that the services are indeed being offered in the way you anticipated, in the way that the person you're supporting anticipates. And then part of what I also heard is a follow-up on the back end, as far as assuring that the person actually received the services that we were hoping they'd receive. So as it started taking a look at warm handoffs and some different definitions, part of what I learned was that warm handoffs seem to have really been initiated or first came from some of our integrated health programs or within a healthcare setting. So some of the things that I saw described there included, even in a situation, if you've ever been in the hospital and you've had nursing care and they change shifts. This happened. My husband had a shoulder replacement about a year ago. And what I noticed that they did is when they changed shifts, instead of the nurses doing rounding in their nursing station on everybody, they actually rounded in your room with you there as an introduction from one nurse lead to the nurse lead that will be coming on the next shift. And that being a warm handoff really in person, where one care provider is introducing, in this case being healthcare, the patient to the other provider. We also saw this in integrated health, as in this definition that we see here, where the primary care provider, or whether that is a mid-level provider, such as a physician's assistant or a nurse practitioner or a physician, is actually introducing. And in here, in this setting, they use the term client, and some of the other ones that are more healthcare oriented, they use the term patient. I think in our really person-centered, recovery-oriented kinds of programming, we really think about participants. But
I also like people that we serve and also community members.
I love that. Community members is really beautiful. That's fantastic. I think about people that we serve quite a bit, although when I'm doing slides, a lot of times it ends up being an awful lot of typing. But I think, our mindset in it, I think it is important for us to think about not just the language that we use, but the culture that we create around the language that we use. So I think all of those things really, really are important. And when peers are a part of the picture, part of what we have an opportunity to do is to really begin to be the voice of the folks that are being served when they're not in the room. And to be able to support our organizations in some of those culture shifts in the way that we perceive and support the folks that we serve. So we see this warm handoff and again, in this particular definition, this is an integrated health setting, and the handoff is between the medical provider and a behavioral health provider. But they're pretty specific that this is happening face to face, as an introduction with all parties in the room together. So that's kind of what it looks like in that particular setting. The Agency for Healthcare Research and Quality, which seems to do quite a bit of support and quality improvement initiatives and so on in the healthcare arena, then they define warm handoffs as kind of transfers of care between two members of a healthcare team that occur, again, in front of the patient. And again, healthcare is using the term patient, and family. And part of what they really value is that it allows the person who's receiving services to hear what's being said, right? And engages them in that communication, and provides an opportunity to correct anything that was inaccurate. And this aspect of this really stood out to me, just as I remembered my husband's experience with the nurses from the 2 shifts. And that was the thing I liked the most about it, is that we were a part of hearing what one care provider was saying about him and his care to the other care provider. And it offered us an opportunity to correct or clarify anything that we felt wasn't being communicated in the way that we would like it to. And really, on the receiving end, we really valued it. So as you look at these 2, right, definitions, how do these align with some of the descriptions that you all shared in the chat? Or just out of, and you can unmute or share in the chat, how close or how far away is that? What pieces align with what you shared in the chat earlier, or the way that warm handoffs look in your organization? And please feel free to raise your hand as well. So Mitchell said, I think it aligns well with what we do. Can you share a little bit more about that? Which part do you feel like aligns the closest with what it looks like in your organization?
We're all peer ran at this point, so its integration with peer workers is already essential to what we do. But as far as how we approach things with our peers, it's entirely their focus and strain, and we're never leaving the call unless they want us to leave. So we're there the entire time.
That's awesome. It really gives them an opportunity, right, to clarify things and an opportunity to have some support. Excuse me, that their voice is being heard. All the way across
that's
the
the one there, getting their voice heard.
Right. So critically, right, important. Anybody else? Breeze, are all of them aligned? That's fantastic. Do you want to share anything more about the 3?
Basically just the only differences were the words, between whether it was a patient or a client or a clinician, or a peer support or a employment specialist. It's anybody that is in any team, as long as we're the client or the patient or anybody is having a new service provided, or even the same service but a new service provider.
Mm-hmm.
It's always that in person. And they don't have to go meet them alone. It's not them going to meet a stranger. It's warm, so they feel more secure. And talking about it in front of them, always asking them if they wanted to add anything, or how they felt about the description, or it all sounded just about what I'm used to.
That's great. Thank you for that. As y'all think about these definitions, one of the things that really came up for me, and particularly as I was thinking about the area of work from the peer COE, where we're supporting organizations that are funded through the Minority AIDS Initiative, as well as where we're thinking about being in organizations that we're integrating peers into a larger, as a part of a larger multidisciplinary team. I thought about, Judy, a little bit about you, and really now that you are a CCBHC, and how that may look in your organization. And one of the things that really kind of occurred to me is that when we think about warm handoffs within a little bit more of a structured kind of healthcare setting, that this could be a really wonderful approach for the process of including peers as a part of the service team, and really bringing peers into a key piece of support that's provided for individuals that are receiving care. So where we're integrating peers into a broader healthcare practice. So for example, I had a call earlier this morning supporting, it was an OBGYN practice that exclusively serves individuals who are pregnant with a substance use disorder, and they want to expand their team to include peer support. And so part of what we talked about were their processes and how they really have an opportunity to integrate peers as a part of their team and really have the medical providers actually be a part of introducing their patients in their healthcare setting, right, to the peers that are going to be a part of their team, and that can really happen as a part of right, a standard prenatal care visit in that setting. So what are some of your thoughts around how kind of these definitions of a warm handoff may fit with or look, how they might look within more of a kind of a clinic or a healthcare setting?
Sharon, there's some comments in the chat from Yolanda and Nia.
So Yolanda, you haven't actually started your position, but congratulations on your position, right? I'm curious how your new employer will handle this, right? We like that the team comes together once a week with the peer, the person being served, that person's in the room as a part of that is kind of what I'm reading there, Yolanda. Am I reading that accurately?
Yes, ma'am. So I like that they, discuss them in front of them instead of feeling like we're just talking about them and not really getting the big, picture, because, they're the ones receiving the service. So they are the ones that, have the best answers. So yeah, I like that part.
Absolutely. And I think right when you do that, when the person we're providing services to is in the room as a part of and a key part of those types of meetings, that says a lot about how we value right, their perspective and what that's a key perspective. When we think about being recovery oriented, that is a really really robust practice in recovery oriented practice. So it's great to see. Sheila and then Mitchell.
Yes, my feelings would be that in so many instances, peers are only used when the organization feel that they need them for detouring of bad behaviors or those kinds of things. But if a peer is going to be a part of the multidisciplinary team, I feel that it's only honorable for the peer as well as the participant peer to meet from the beginning of the program until the end, because that's when rapport is going to be built.
Absolutely.
That's when rapport is going to be built. The participant is coming to a new institution, and here during the warm handoff, they're meeting someone, a peer that works there that can identify as a peer to make them feel comfortable amongst the other multidisciplinary team members. I think from the beginning of entry to the ending of exiting.
Well said, Sheila. Thank you. Thank you. You really helped me really remember too that we're not right, as peers, we're not an ancillary afterthought member of a multidisciplinary team. We are a key and integral member of the multidisciplinary team. So we function in the way that you're describing. That really conveys that message to folks that are being served, as well as all of the staff in the organization. So, Mitchell.
I agree with Sheila completely. I think especially in a clinical setting where we're talking about peers taking on the roles of more guardian ad litem, where we're talking about they represent the peer in the setting where the peer is not present, and they have to maintain those values and what the peer would want in those situations where they don't have voice. But as regards with note taking, I think it's especially crucial to include the peer, because oftentimes the peer is not able to communicate. I find myself, I can't communicate appropriately with a person to understand what I'm trying to convey. I don't know the magic words of the clinical term or what experiencing I'm having to convey to you so that you can understand that experience. I only have so many similes in my repertoire to share with you for you to latch onto those experiences. So being able to see those notes and know that's what you're reading from what I said, and we can stop and establish the corrections that may need be of, but that's not what I meant, or let me clarify this because I think you misheard. There's a lot that can happen there, and that can affect your treatment plan and your goals and how the treatment team views you. And that's very crucial for moving forward and for getting those treatment needs and having that rapport with the peer.
I love that. You bring up some really good, right? Really, really good points, particularly around language and notes, and said multiple times in different trainings that when we wanted to really kind of, one of the ways of assessing are we truly recovery oriented in our culture and in the way that we do things is that how we would feel if folks we provided service to read our notes. And if that's something we're uncomfortable with, there's some things that need to change, right? And
I think we need a question, is there a space for there not to be notes? Because there's definitely times when you can feel more comfortable talking, knowing that nothing is leaving this room so that you can truly be real with another person.
Really, really good point, right? When we think about, I think the things that we bring sometimes that can, right, challenge different kinds of settings. That's something that is, I think, important to, right, to be able to start thinking about, to have folks really think about how documentation may get in the way of folks being able to be truly open, and how do we find, I think, sometimes the balance between realities, what may be in a healthcare organization, and creating a level of comfort and safety for folks that we're serving to, as you said, right, be able to feel like they can be completely transparent and open. So part of why I love being able to be a part of these is it gives us a lot to really to think about and to talk about, and the ability to always be able to step back and kind of question and reconsider the way that we've always done things is really valuable. So I want to kind of move forward a little bit here and be able to take a look at, right, the peer worker's role specific to the functions of system service or system, right, navigation. So I think last time that I guess it was last month that I facilitated one of these trainings, we looked quite a bit at the peer support toolkit from the city of Philadelphia. And one of the things within that toolkit, it lists some of the peer support core functions. And so I revisited that and really looked at, out of all the core functions there, which are the ones that really align with this, where we might be in the role as a peer of making referrals. So, and I think about those definitions of warm handoff they offer that we just had in this last section. They offer some ideas around ways of integrating peers, and then they also offer some ideas around where peers are actually, right, are the ones who are making the referral, and that may happen within the function of a sort of linkage, which is going to include, right, a variety, I think, of activities, including, right, identifying, mapping, and as well as developing, right, some of the recovery resources that that folks need in the broader community, being able to link folks or get folks right connected with those community resources, as well as helping them navigate the community resources. I think one of the first, I think when I made my right flippant remark about warm handoffs, maybe they're warm and they're not a handoff, it was really in line with some of this thinking that, you know, we don't make a referral where it's simply like, oh, here you can go to this organization and they can help you with X, Y, and Z. It really is about supporting folks and ensuring that those services actually end up being delivered in the way that they were expected and intended, and helping folks really navigate what frequently can be a pretty wide array of service providers, right? Depending on what a person's individual right vulnerabilities and assets and needs may be. We think about, right, all the different kinds of social service needs that somebody may have, right? Exactly, Mitchell, right? Verify your referral source, right? Otherwise, we're making blind referrals, really, when it comes down to that. So, right, listed here are just a few different things, right, where folks, needs that folks may have. I know for me, I focus quite a bit, again, on that population of pregnant and parenting people with substance use disorder who frequently have some pretty complex needs for themselves and their family. And then also, you know, added in here is, right, how as a peer, what are some of the ways that we may go about really kind of exploring with somebody to help them identify what kind of other service needs that they may have. And there's a variety of different ways that we can approach that in partnership, right, with somebody that we're supporting, whether that's looking at leveraging some different kind of tools, such as like a social determinants of health screening, or maybe recovery capital assessment, where we can really kind of come together and partner with someone to explore kind of where things are at for them currently and where they might like things to be in the future, and what their priorities are, and have that kind of help be a big piece of guiding that process. You know, there's also the function for peer support of health system navigation. So it's a little bit more narrowly focused around healthcare, but really is involved in supporting both individuals as well as their family members, and connecting folks to culturally relevant health services that are available and that they are interested in being able to be connected with. And that really covers kind of across the spectrum of whether, again, in healthcare, you know, prevention, diagnosis, treatment, right, recovery management, as well as the kinds of follow-up service we know so often when it comes to folks that may be experiencing substance use disorder, as well as folks that are experiencing HIV/AIDS. There may be, right, other additional and complex medical situations that folks need some support around. And that can really feel, I think, for lots of folks, really very overwhelming, because it can be multiple things at one time, and going to so many different kinds of places and a wide variety, right, of phone calls and appointments and all the things that go along, right, with that. So a lot of support around navigation makes that a less, right, stressful process, a more successful process. And some of the research around warm handoffs and integrated support also has shown that, right, it increases the chances that folks will be able to actually access and receive the healthcare that they are interested in. So Mitchell is pointing out, right, the importance of open questions, right, and the ability to time and ability to access these different kinds of services, and all the things that go along with that for folks, which may be additional financial resources, transportation resources, childcare. Very right. It's a comprehensive whole person way, really, of looking at things. And so when we look at, right, the roles of a peer, I think what, you know, part of what we bring to peers, to the role of the peer, is when I look at the role, and initially, I think when I was first really diving into some of these things several years ago, I remember having some pretty robust conversations around what's the difference between role and function. So I'll share what we landed on, is that no matter what the function is that a peer worker is engaged in, that at least, right, one or more of these particular roles is a part of how we do what we do. And so I'm I think, a strong advocate for what's important about, right, how we are and how we do, right, what we do. So, right, no matter what the exact function that a peer is engaged in, whether that's health system navigation, whether that is assertive linkage, we want to think about, right, how are we bringing our unique lived experience, right? How are we providing emotional support within the broader context of those kinds of function? Those are going to be pieces of things that we're always going to be aware of, we're always going to be attending to, and always bringing in right to the work that we're doing day to day. We're always thinking about as well, right, when we look at this affiliation role, it is always really having, right, an ear to and a thought to, does the person have the level of broader support in their life that they would like to have? So one of the things that I've been known to say frequently is that part of our role is helping to support folks and growing the support in their life that's not paid to be in their life, right? Oftentimes, I think when we get into, and particularly when we're thinking about referrals, sometimes we can get into that space where we think of more services, and more services. And along with that, we always want to be remembering what other supports, right, do folks have? What does that look the way that they would like it to look? And if it doesn't, right, how do we help folks grow the support in their life that extends beyond, right, service providers, or like I say, right, folks that are paid to be in their life? That information role. And this is such a key piece and really, right, connected to these functions of assertive linkage and health system navigation, is making sure that folks really, right, have a good understanding. They've received the information and other kind of assistance so that it's not like a blind referral, right, for the person accessing other services, right? And I think in some ways, these things get connected with each other, because that role of emotion, I can really, as a peer, weave into information and really join in, right, at a mutuality with somebody around making sure that the services are indeed the things that they are interested in receiving, and in the long run are going to be a match for the expectations that they have. And then instrument kind of goes right in line with this, because that really is around, right, the role that we have in concrete assistance. And a lot of referrals are around getting other kinds of concrete assistance. But these roles really work, I think, in coordination with each other to provide, right, a level of support for folks that goes really well beyond a simple referral. So as you reflect on the roles of the peer worker, right, how does this approach, right, we think about the roles of, right, of emotion, affiliation, information, and concrete support, how do those roles really create some differences between the approach and the practice of a peer and other members of the care team, such as case managers or community health workers? What are some of your thoughts around how the role of the peer, and again, right, when we come back to the role, when we look at emotion, affiliation, information, and instrument, how does that make this role look different? Mitchell, I was counting on you. Thank you.
So they each have their own agenda, basically. They each have their own representational role. The community health worker has to look at what's best for the community. So if there's issues with the peer that are have concern to the community, or they have clinical requirements, or their employer has standards and requirements that have them that would go against what peers' core values would be, or what the clinicians' standards are, or what their current their thought is, because every clinician has different takes on how they view things as well, and how they interpret it, and what they're researching or they're conducting as well. So there's different roles that each one plays, and they all can benefit the peer or the member of the healthcare patient. It all depends on how that view is and how that person is recipient to those, is really what it comes down to, is what services they want are going to be what's going to be most absorbed. And it's just providing all the options to them, because even as peers, we don't know everything. everything. We don't know all the options available. So it'd be ignorant of us to ignore the advice and counsel of our colleagues in this, because that's what we are in this. We're a part of the team. So we should all be considered and give those other considerations their due.
So thank you. Appreciate that. You have a lot of wisdom and great experience that you bring to this. So some of the things that I'm seeing in the chat as well, right? Peers have, right, that lived experience instead of just book learning. And then, right, with it, we may have been in that position ourselves. And so we know how we want to be treated in that instance. So Elizabeth, that is right, so true. Bree, right? Physical health workers are often trying to solve the problem quickly. And peer support workers use motivational interviewing and support to allow the client to come to their own conclusions and solve, right, their own problems. And I love one of the things that you point out here, Bree, that I think is so important to keep, right, to always to keep in mind, and that sometimes we find ourselves continuing to have to advocate for his time, right? And the time to do exactly what it is that you're talking about by utilizing, right, those open-ended questions, by really exploring with someone what the barriers are. So if I think back to what Mitchell had typed earlier about, you know, making sure that folks really can access services. Are there transportation issues? Is there a need for childcare? Those are the things that we learn when we take time and have the time, right, to really listen and engage in conversation and really meet folks where they're at. So that's just a really, I think that's such an important point, Bree, because that does take time. Anybody else have anything else that they'd like to add to that?
Can you hear me?
I can. Thanks, David.
Hi. Yep. I want to say thank you for this. I appreciate it. I work in the healthcare field. I am more so now on the insurance side, working with a health plan. And so as a peer recovery, as a peer recovery specialist, as a peer recovery coach, supporter, I am now program coordinator too. So the connection, as you talked about the emotion, the affiliation, instrumental, and we connect not just with the peer, but also with the individuals that are serving the peers. So from my position, what I have to do to facilitate that, I just don't facilitate it to the outside agencies, but I have to give the individuals that are on my care team an understanding of what it's like for an individual emotionally at this stage of their recovery, this early part, how it's important to inject recovery after they have been through several treatment stints. And take, for instance, an individual had been to treatment on several occasions in partial hospitalization and even completed it on a couple different occasions. However, this the last occasion. It's like, okay, so after he completed it, what is it, 60 days later, the CM says, hey, I haven't heard from this person. And then when they finally get a hold of me, they tell me that they used. So since they relapsed, what should I do? Should I refer them back to partial hospitalization? The first thing I did was recognize the language that she used. The person said that they used. They didn't say they relapsed. So there's a difference between use and relapse. So where was the person at? Were they in partial hospitalization when this happened? No, where were they at? They were in aftercare. Okay, so address that issue in aftercare so that we can get a better understanding on where this member needs to be. So I'm saying all that to say that it is important for us to understand that the affiliation, the information that we provide is very instrumental, and our affiliation with the recovery community is vital when it comes to helping people access care, and the communication process with those individuals that have, as she mentioned, the book learning and don't have that lived experience is very important, that they know that when an individual is processing through the pathway of recovery that they have chosen, everything may not be cut and dry like we would hope it would be. There will be ups, there will be downs and ins and outs. And we have to be accepting of who the person is as an individual so that we can support them in their recovery that they've chosen.
Well said. Very well said. One of the things that I frequently you think about, and I've said to folks who haven't had this the lived experience is that the ability to help others on our team, right, understand what it feels like to be the person who has struggled with substances and is working to try and move into recovery and is struggling there. And I think sometimes the emotional experience of finding yourself in situations that you didn't want to be in and not being able to kind of navigate how to stop being in that space, what that feels like. Sometimes I think even having lived it and experienced it, I have a hard time finding words that can adequately explain to somebody what that feels like. And then I feel like for the person in recovery, when you're sitting with someone who gets it, who knows what that feels like, it helps you relax and think and communicate. And I think oftentimes it puts us in a space where we're best able to find the solutions that we have inside of us that we didn't know were there. There's just so much, right, to be said for right, the value of lived experience, right, all the way around. So Mitchell, you shared some things in here around, I'm trying to read the context, especially if you said I was so good at it, and now I'm feeling like, all right, I'm missing it here. So if you can share a little bit more, I'd appreciate it, because
so a lot of time in our role, we get a lot of flack, I guess. We get a lot of kickback from the clinician team or from others who don't really understand our role and think that we're supposed to be on their side fighting for them. But a lot of times clinicians focus on the symptoms, right? They focus on what medication you have anxiety, you have this, you have these issues that you need treated for, as opposed to what's causing these issues. And the peer supporter has that capability of helping the peer find those causes, because they have the answer of what the causes are. The peer doesn't. You know, I as a supporter don't, but the peer knows what's causing all these stresses in their life that are causing these anxiety attacks or all these other things that they can identify and then find resources for or learn to manage so that they don't need other services, which the clinicians not necessarily want, because they want the service. They want you to go through the service because that's how they're paid and funded, where we're contrary to that in the sense of we want the peer to be successful. And that can look very different, although, and a lot of times it's confused, like I mentioned, with like holistic and energy therapy, just like people would view that as non-productive or not helpful or hokum or whatever. But if the peer finds that helpful and meaningful to them, that's really all that matters. And whether it works or not is up to that perspective.
Right. So we have the ability really to look well beyond the services that our organization or our particular care team, right, is able to provide. And so, right, Judy, I can see what you're talking about too, that we also need, right, and really we and those that we serve really benefit from the other members of the care team. I like we talk about the circle of care. And so our care teams, case managers, I think that they're right. All of our roles are really, really valuable. And right, folks, I think being able to access and be connected with a team that's really working in good coordination with each other, right, is the best possible opportunity for folks. So when we think about, right, being able to connect folks with services outside of our organization, right? So then we're thinking about, right, external referrals. And in a lot of ways, and I've felt this way for a very long time, that some of our best referral best practices oftentimes are really grounded in, they put on here, robust, because I like that word, robust collaborative relationships, right? That the stronger our relationships are with across organizations, but also across individuals, right, within organizations, because in a lot of ways it comes down to that as well. That's a piece of referral best practices. So I want to give you all an opportunity to connect a little bit more with each other. It was really interesting. I'm always, whenever I am preparing any kind of a presentation, right, my best friend is Google. And I'm always wanting to, you know, see like, well, what's out there? What's been written about this? So it was super interesting, but I didn't find a ton written about referral best practices. I have my own Sharon's ideas of what I think is best practice, and certainly made those a part of the way that programs that I was involved in operated, but it's certainly not the be all and end all. It's just one person's idea. So I thought this, having so many of you here, is that this is a great opportunity, right, to hear from and kind of gather collectively, right? What are some referral best practices? So we're gonna have you in, we're gonna move you into breakouts, and it looks like Cindy is gonna set the breakouts because I don't have that button.
Go. Okay, how many people do we want? No, I got it. Don't worry.
If you can do it so that we have like 5 breakout rooms, that would be
Sure.
awesome. But don't
Sure.
send everybody yet. And
I won't.
So when you all get in the breakout, and there's for 5 minutes. So when you all get in the breakout, if one person can just like go, hey, I'll take care of being the reporter, because you all know 5 minutes goes super fast. And because that person will just report back out on behalf of the group. And really all you're doing in your breakout is coming to agreement on what you think are the 3 most important elements of an effective referral.
Okay. All right, I'm going to click the button in just a second. Let me apologize in advance for the abrupt way these end. We're going to have about 5 people in the room, so a minute per person would work. It's not mandatory, and if you seem to be in a room alone, hang on, I'll come in and move you, okay? Here you all go.
I do think you have to click yes that you will go.
Oh, yeah, it'll ask you. So I'm closing a couple of rooms as I join them to other folks.
Okay, thanks, Cindy.
Yeah, they're gonna move.
I think sometimes too, if folks had to step away.
Yeah. Yeah, and I see there's people here still with us. So the minimum we have is 3 in a room.
That's pretty good because it's
I think we're okay. So I've got 108. So
my guess is that
113.
this is an amazing group of people, and even with 3, they would have
are.
no problem coming up with 3 elements of an effective.
No, this is a very cool group.
I agree.
Oh, wait, Ashley's all by herself. Let me move her.
Somehow in my head, I got it, like, I'm really used to being in Eastern time and then converting it in my mind to Central time, but being in Central time and switching it in my mind to Eastern time works differently. And we're
It's
done
challenging.
At like 3:30, but we're not. We're done at 2:30.
And I always forget to put Eastern. So
and everybody that I work with regularly is just like assumes it's like we learn where each other, right, what time zone each other is in. And so I've been trying to, with my Eastern time friends, just like switch it to Eastern time since they assume that's where I'm at.
We were just back east and my computer stays on Central time, but we had an all teams meeting and none of us were sure, like, well, wait, is it 11 o'clock Central? So we were all a little bit challenged.
My computer, I think it's because the Mac does this. My computer, my phone, everything converts every single thing in my calendar to the current, whatever time zone it's in.
That's awesome.
which is
Okay.
helpful.
It is.
Jennifer, you just joined. Wait, I'll wait till you're connecting to audio. Jennifer, I don't know if you've been with us and jumped off and are back in. We're in breakout rooms for another 2 minutes. So if you don't mind hanging out with us,
We're
that
lovely
would be
people.
great. Most of us are. No.
We try
And I
to-
hope anyone else that's still here in the main room with us, raise your hand if you want me to scoot you into a breakout.
Or you can hang out with us lovely people.
Hang out. Yeah.
Hey, Jennifer.
Yeah, sorry, I was on and then I got disconnected when I actually hit the wrong button.
I do that.
I do that. And then I think sometimes people, I find that people get booted out in the process of joining breakout rooms, and it's not anything that they did. It's related to their bandwidth.
Yeah.
So you could blame it on that.
I could, but the truth was it was my finger.
That finger.
Where are you at? Where do you live? Where are you at, Jennifer?
Phoenix, Arizona.
Oh, that
Yeah.
sounds really nice right now.
It is. It's like about 60 something, 70, 60, 70.
That'd be good. I was doing training the last 2 days and everybody was from Florida, and I was sitting here in Iowa looking at the snow out my window. And they wanted
And
me
they're
to
probably
take the
looking at the
computer.
sun, right?
Oh, they're all like, take your computer to the window so we can see the snow.
Yeah.
Sounds like something I would say. Show me the snow.
Yeah, the first snow is great. Anything after that? I'm
First
done.
one, yeah. Anything after.
Late February, it's terrible.
I've
Well,
decided that I'm good for life. I don't need to see snow ever again, and that'd be fine. I've
I'd
seen
be
it.
okay with that.
People from the desert only see snow in the movies, so we think it's incredibly beautiful. So
Very
that's
pretty.
what we.
Come
That's
to
right.
Iowa, Minnesota, there's snow.
Yeah.
No,
it's
that's why
pretty.
you guys come down here for the winter.
There you go.
I
It
love
sounds
Phoenix.
like a great, better and better every year that I get older. I'm like, yep, I want to be a snowbird.
See, there you go.
Yeah.
You could just say, you know what, I'm going to work Zoom for 6 months of the year, and then I'll come back in the summertime.
That's what
There
my
you
brother
go.
is doing. My brother and his wife are going to Scottsdale, and for 3 months they got an Airbnb or a rental of some kind. And
That sounds like a
Okay.
great plan.
I told
Isn't
them,
Okay, ladies, I'm gonna interrupt
bring
you.
it back?
I'm gonna close. This is not my main computer. I'm on a loaner, so I don't know what the settings are. They could all jump back, or they could be back. They could give them 60 seconds. So I am gonna close the rooms. Okay. Yeah, gives them. This is 60 seconds. So
okay. And I am going to stop sharing for a moment so that folks can see each other better.
cool.
Let me do this.
I was trying to find my background because I have a few people here. And I can't find it on this screen. Echoing.
This is my favorite part of Zoom, which is when everybody comes back from the breakout room and it feels like magic. I feel like we've lost some people though.
No, still got 17 seconds left, and there's still lots of rooms that
okay.
are probably going strong. 5 minutes feels like 1 minute when you're in a breakout and the conversation gets
true.
going. So yeah, like 3 more seconds and they should all dump back in.
Oh yeah, here comes everybody.
Yeah.
Plus, when y'all come back from the breakout rooms, more of you have your camera on. So it really is like magic.
Up here.
I find amusement in everything that I can. All right. If you are the person who volunteered or volunteered, either one, to be the reporter for your group, if you can raise your virtual hand, which if you move your mouse along the bottom of the screen, there's a little button towards the right-hand side. that says reactions, and that'll let you raise your hand. And Donna, you are the winner of the hand raising contest. So you get to go first. What were the three practices that your group came up with, or elements?
Okay. Let me move my mouse. Can you hear
Okay.
me?
Yeah.
Okay,
I
good.
can.
I've been having computer problems all day. The first one we have is identifying referral needs and getting consent from the peer. The second one is identifying good connection, fit, and availability for the peer, and then speaking directly to the peer and provider to break down barriers for the good connection, fit, and availability. And then the third one is great follow-up, because we are awesome peers.
Yes, you are. Wonderful. Thank you.
You're welcome.
Nia, you're next.
All right, let me go ahead. So our first one was that it would be desired and targeted, that it's needs-based. Second was that it's accessible, that it's local, timely. The financial aspect, is it covered by insurance? Is it free? Is it discounted? That it's reasonably attainable resource. Also that it's measurable. What is the turnaround time to attain? And that it's verifiable, that it's still a valid, accessible resource.
All right, you all crammed a bunch of stuff into that one thing. That's awesome. David.
Okay, the three most important elements of a referral: know where they want to go before transferring them, that they're aware of the transfer, asking them open-ended questions to find out what is it that they actually want and where they want to go. The different, and that's done by using different methods. What is their goal and their expectations? I generally use the PIG. What is the problem? The problem may not necessarily be substance use. It could be something different. So find out from them what the problem is. What is the intervention that is needed in this situation? Do I need to send them to a place that's going to provide extensive services, or do I need to send them to a place that's going to provide them with outpatient services based on their substance use needs, what have you? And then the goal. What is the goal? What are their expectations? I don't want to send them somewhere where they have an expectation that's totally different. So find out what is it exactly that you're expecting to receive from where you're trying to go. So if I know what the problem is and what you intend to receive from where you go, then we can understand that the goal can be mapped out appropriately. And that's ours.
That's awesome. I like that acronym, PIG. That's great. Bree?
So we talked about each of our, experiences, and what we found. First one, we talked about clarity of expectations. Having the person tell you, what they need to be working, or what they want to be working on, what their goals are, and then to share as much of the information as you can, based on who they are, what they want, the progress they've made, what they've been working on, and then yeah, like what the other guy said, the aware of the transfer, that they're still voluntary, that they want to, keep going with the program, and clients understanding why there's a new service provider.
And does it, yeah, and it won't, right, it doesn't always mean, this is one of the things we think about where we came up with kind of the title to this, is that it may be warm and we may be connecting folks with other services, but they may also still be right with us. It's not always right that they're leaving our services, but that they may be adding additional supports and services. Awesome. And let's see, Katie.
So we opened up, we all agreed that open communication is key, making sure it's what the client desires, the participant desires, so making sure it's their choice. Also, for a referral to be effective, something known as like a backdoor referral. So having those prior connections, community ties before you are meeting with the client. This is important because often we will be trying to connect them with community resources, and there will be either like no beds available, nobody answers, just different barriers. And so if you have like that, you can go straight to the source, you have a contact like an email or a backdoor phone number, that can be super helpful when processing a referral. Also, what was brought up was location. I'm blessed to live in a city where there's a lot of resources, especially in the recovery community. But for more rural areas, it was brought up that there is often problems with not having a feasible location, or having just like off the wall referrals that are like from across the country. And so just like making sure that you've done your homework, and that it is useful for the client to have an easy location to get to, or virtually vice versa.
Fantastic. So thank you all so much. So as I'm listening and I'm writing, if I was looking like I wasn't looking, I was writing some different notes down. I'm definitely old school and end up writing things, handwriting rather than typing. But some of the things, that we heard over and over again, and I think right at the very top and front and center is really that referrals need to really be based on what is the desire and interest and goals of the person that we're supporting. So, no surprise there that would really rise to the top. The other piece that we heard multiple times is that in addition to the service being something that the participant is really interested in, that we have to, whether it's through doing our research, building relationships, connecting with other people maybe who have utilized the services, making sure that it actually materializes as what we thought that the service or support was going to be, that we're not just sending folks to an organization that we heard does X, Y, or Z, but that we've really done the research to be sure that it will unfold in the way that the person we're supporting is expecting, and so that it's going to meet the needs that they state that they have, the expectations that they have for the service, that they're able to actually truly access it, whether that is via, because of distance or transportation or any other kind of barriers, that it is realistically available and accessible for folks. And then the other thing that I heard several times was about following up and being sure that things actually unfolded and materialized in the way that both the person we're supporting and that we expected. So, which are definitely the things that you all came up with. If someone was going to write an article, not that I'm looking at doing that, just wanted you all know I wasn't just picking your brains for something to go write an article around, but if someone was going to write an article on best practices for referrals, the things that you all came up with would be the things that really should be there and be a part of it. One of the things that that I heard that always stands out to me, and this has certainly been aligned with, I think, my own experience, is really about the importance of relationships. And I'm going to jump ahead in my slides, which I had a feeling I would end up needing to do. But I think, and I am definitely one of those people who know me well and have spent time with me, they're never surprised when they hear me say relationships are at the center of everything. I think someone was using the term, and I think I don't know if it was Katie or if it was the person before you, Katie, maybe it was Bree, who talked about kind of backdoor referrals, but really about the importance of knowing folks in organizations across our community. Sometimes I think that building relationships gets kind of looked at as sometimes as fluff or those nicey, touchy-feely kind of things. But in reality, relationships are absolutely essential, We can't build good collaboration, effective collaboration, really effective and responsive referral networks and resources across our communities without relationships. And it's really critical that those relationships occur in a couple of different ways. One, between the individuals who are providing services directly to folks who are seeking services, and at the same time also at an organizational level, because we don't necessarily, we always have to try to balance both good relationships between folks that are providing services directly to folks, and at the same time we want how smoothly and how well we're able to network and support referrals to not always be person dependent, right? Because folks can find other jobs or go from one organization to another. And so we want to be thoughtful about organizational relationships as well, so that they're not 100% dependent on any one individual person, that they continue to work and stay strong as individual staff change over the course of time. So it's important that relationships are at a variety of different levels. So that kind of brings us to, well, what kinds of things can we do, to kickstart relationships? I think sometimes across peers, particularly, we may be involved in a lot of recovery activities across our community and have great opportunities to meet and connect with each other. I think, for me, in the experiences that I've had over time, is that I have found that when we really are wanting to really be deliberate about establishing and growing really strong relationships across organizations, that when we partner on things like a community event or a conference or some kind of a fundraiser, or we partner together to host a support group, or because I've worked in so many services for families with young children, we would partner across our community to jointly sponsor a lap sit at the library, so that could be offered every single week for a family, or a play group that happened every Friday and we took turns staffing it. When organizations maybe partner together for their community to develop a resource directory, one of the things that happens during these other kinds of activities is we will naturally build great working relationships with other people in our community, because we have found something as a common goal that is, I always feel it's kind of a low barrier goal. It's something that we all can get behind, and that it's easy to create a common vision. And then we can really leverage those relationships that have grown through one activity to really support great community collaborative systems where we live, and to the benefit of the folks that we are serving. And the other activities that we come up with are also to the benefit of folks that we provide services to. So those have been some really great strategies. And just a kind of closing thought, one of the things that doing so much work in a virtual environment has made it more challenging, to build some of those relationships. Typically, if I was going to something just exactly like this today that was in my community, I might get there 5 or 10 minutes ahead of time. I might chat with the person that I'm sitting next to. We may walk to our cars together afterwards. There's a lot of opportunity before and after things that are in person to connect. So I do a lot of training as a part of my work, and we're always looking at ways in Zoom to or other virtual environments, to create connections. So we've made it a habit to open our meeting rooms 5 or 10 or 15 minutes early for folks who just want to connect over virtual coffee. I try really hard to make small talk or to just create conversation, because the weirdest thing in the world is having 15 people in a Zoom 5 minutes before a meeting starts and everyone's just looking at each other and no one's saying anything. And so we can use that time. Anybody who speaks up and creates conversation is really doing their part in helping to create relationships, and just kind of be that person, or even to create space for folks to just have open conversation. That's one of the things on a couple different projects I work on, where there's a number of people who are working on the same project, and we actually have a meeting once every other month where we has no agenda. It's just to talk about what we think, what our ideas are, what our dreams are related to the project, and then to generate ideas and interesting conversation among us, the kind of conversations that maybe we used to be able to have when we were all in offices together. So I don't know if any of you have experienced any great strategies for building relationship in a virtual environment, but if you have, please feel free to share those. All of the resources and references for what I presented and some of what I didn't present is in the slide deck. So when you all get that, you have access to the resources that were used. And I don't want to ever keep you all over, even though I'm pretty sure that you're going to stay. Say more, Mitchell. Other peers, connecting with other peers.
So I'm part of the National Peer Support Warm Line Council, and we're building a Discord referral service, or not necessarily referral service, but just like a Discord amongst the many states where all of us are putting in information of accessible resources that we've used or utilized currently. So if we can break it down even further to county-based as we grow and get more national resources to on the local level involved, then we have a constant source of resources being utilized and upkeep. It's just currently being built still. It should be launched in January. So be on the lookout.
So have you met awesome and amazing people through this process?
Yes, NAPS, the National Association of Peer Supporters, Christina Ansira by name, Tara Wilheim out of Wisconsin, as well as Stephen Larson, Vanessa Williams out of Virginia. The names go on. There's just connections all over. If you're willing to take the time or have the time to meet with people and just hear, listen, and feedback, ask questions.
It's such a great example because I think it illustrates part of what I was talking about projects like this create opportunities for building connection across our field. And I think they add a lot of richness to our work too. I mean, I love being able to work with lots of different people from lots of different places because it expands how I see the world and what I understand. And we end up with something really incredibly valuable and meaningful for folks that we are supporting in the process. So it's such a huge win all the way around. So thank you all so much for joining us, for contributing to this, for sharing your wisdom as a part of our time together today. This is anytime I get to do this stuff with the Peer COE, I love it because it always helps me. It's like in my head, I know like we are strong and we are mighty and there's a lot of us across the country, but when we're together in the same space, I feel it in a way that's not just in my head. So thank you all for being a part of this.
Thank you, Sharon. Another
Thank
great
you.
meeting.
Thank you so
Thanks,
much.
everyone. And yes, you'll get my follow-up email within a week. Okay.
Thank you. Bye, y'all.
Thanks,
everyone.
Evaluation. Our next training is on compassion fatigue on Wednesday, December the 7th from 1 to 2:30 p.m. Eastern. And we invite you all to come back with us. You'll see the emails.
What time is
Yeah, the
Central?
registration isn't up yet, but it will be soon. I'll make sure and include it on the follow-up.
Thanks
Thanks all.
Bye, y'all.
Bye.
Bye.
Happy to participate. Thank you.
Thank you so much. Take care. Thank you, Sharon. Great job.
You.